Greetings to all aspiring healthcare professionals and educators joining us from across the globe. I am Professor Dr. Anas Rashid, and it is my distinct pleasure to welcome you to our comprehensive and interdisciplinary journey through integrated pharmacology and therapeutics. With a European PhD in vascular medicine, physiology, and pharmacology, complemented by extensive postdoctoral training in experimental medicine, surgery, and translational medicine, I bring to this series a deep-rooted passion for advancing knowledge and fostering collaborative learning experiences. The lectures are organized as follows. Let's get started with lecture 1, general pharmacology and questions with answers. Definition. Pharmacology is a term taken from Greek word pharmakon, meaning poison in classic Greek, and in modern Greek, the meaning is drug. Study of substances that interact with living systems through chemical processes, especially by binding to regulatory molecules and activating or inhibiting normal body processes. Therapeutics, taken from Greek therapeutikos, meaning inclined to serve. Treatment and care of a patient for purpose of both preventing and combating disease or alleviating pain or injury. Routes of drug administration. These are determined by properties of drug, for example, water lipid solubility, ionization, and by therapeutic objectives, for example, need for a rapid onset, need for long-term treatment, or restriction of delivery to a local site. Enteral, administering a drug by mouth, common, convenient, and economical method. Drug may be swallowed, allowing oral delivery, or it may be placed under the tongue, sublingual, or between the gums and cheek, buccal, facilitating direct absorption into bloodstream. Oral, many advantages. Oral drugs are easily self-administered, and toxicities and or overdose of oral drugs may be overcome with antidotes, such as activated charcoal. However, pathways involved in oral drug absorption are most complicated, and low gastric pH inactivates some drugs. A wide range of oral preparations is available, including enteric coated and extended release preparations. Enteric coated preparations. Enteric coating is a chemical envelope that protects drug from stomach acid, delivering it instead to less acidic intestine, where coating dissolves and releases drug. Enteric coating is useful for certain drugs, for example, omeprazole, that are acid labile, and for drugs that are irritating to the stomach, such as aspirin. Extended release preparations, abbreviated ER, XR, XL. SR are sustained release. Extended release medications have special coatings or ingredients that control drug release, thereby allowing for slower absorption and prolonged duration of action. These formulations can be dosed less frequently and may improve patient compliance, may contain concentrations within therapeutic range over a longer duration. These are advantageous for drugs with short half-lives. For example, the half-life of oral morphine is 2 to 4 hours, and it must be administered 6 times daily to provide continuous pain relief. However, only 2 doses are needed when extended release tablets are used. Sublingual route involves placement of drug under tongue. Buccal route involves placement of drug between cheek and gum. Both sublingual and buccal routes of absorption have several advantages, including ease of administration, rapid absorption, bypass of harsh gastrointestinal environment, and avoidance of first-pass metabolism. Parenteral, drugs directly into systemic circulation. Parenteral administration is used for drugs that are poorly absorbed from gastrointestinal tract, for example, heparin, or unstable in gastrointestinal tract, for example, insulin. Parenteral administration is also used for patients unable to take oral medications, unconscious patients, and in circumstances that require rapid onset of action. Parenteral administration provides most control over drug dose delivered to body. However, this route of administration is irreversible and may cause pain, fear, local tissue damage, and infections. 4 major parenteral routes are intravascular, including intravenous injection or intraarterial injection, intramuscular injection, subcutaneous injection, and intradermal injection. This figure represents subcutaneous and intramuscular injection. We can see epidermis, then dermis, then there will be subcutaneous tissue, and then the muscle will come. Intravenous, most common parenteral route, useful for drugs that are not absorbed orally, such as neuromuscular blocker, rocuronium. Intravascular delivery permits a rapid effect and a maximum degree of control over amount of drug delivered. When injected as a bolus, full amount of drug is delivered to systemic circulation almost immediately. If administered as an IV infusion, drug is infused over a longer period, resulting in lower peak plasma concentrations and an increased duration of circulating drug. Intramuscular. Drug administered intramuscular can be in aqueous solutions, which are absorbed rapidly, or in specialized depot preparations, which are absorbed slowly. Depot preparations often consist of a suspension of drug in a non-aqueous vehicle, such as polyethylene glycol. As the vehicle diffuses out of muscle, drug precipitates at injection site. Drug then dissolves slowly, providing sustained dose over an extended interval. This figure shows the plasma concentration of midazolam after intravenous injection with red color and with intramuscular injection with blue color. Subcutaneous. Like intramuscular injection, subcutaneous injection provides absorption via simple diffusion and is slower than intravenous route. Subcutaneous injection minimizes risk of hemolysis or thrombosis associated with intravenous injection and may provide constant, slow, and sustained effects. This route should not be used with drugs that cause tissue irritation because severe pain and necrosis may occur. Intradermal. Route involves injection into dermis, more vascular layer of skin under epidermis. Agents for diagnostic determination and desensitization are usually administered by this route. Other oral inhalation and nasal preparations. Both oral inhalation and nasal routes of administration provide rapid delivery of drugs across large surface area of mucous membranes of respiratory tract and pulmonary epithelium. Drug effects are almost as rapid as are those with intravenous bolus. Drugs that are gases, for example, some anesthetics, and those that can be dispersed in an aerosol are administered via inhalation. This route is effective and convenient for patients with respiratory disorders such as asthma or chronic obstructive pulmonary disease because drug is delivered directly to action site, thereby minimizing systemic side effects. Nasal route involves topical administration of drugs directly into nose, and it is often used for patients with allergic rhinitis. Intrathecal, intraventricular. Blood-brain barrier typically delays or prevents absorption of drugs into central nervous system. When local rapid effects are needed, it is necessary to introduce drugs directly into cerebrospinal fluid. Topical. Topical application is used when a local effect of drug is desired. Transdermal. This route of administration achieves systemic effects by application of drugs to the skin, usually via transdermal patch, as shown in figure B. This is a transdermal nicotine patch applied to the arm. The rate of absorption can vary depending on skin physical characteristics at the site of application as well as drug lipid solubility. The figure A shows the transdermal patch systemic representation in which we have skin, clear backing, drug reservoir, drug release membrane, contact adhesive. So drug diffusing from reservoir into subcutaneous tissue. Rectal. Because 50% of drainage of rectal region bypasses portal circulation, drugs by transformation by liver is minimized with rectal administration. Rectal route has additional advantage of preventing destruction of drug in gastrointestinal environment. This route is also useful if the drug induces vomiting when given orally, if patient is already vomiting, or if patient is unconscious. Rectal absorption is often erratic and incomplete, and many drugs irritate rectal mucosa. This figure summarizes characteristics of common routes of administration along with examples of drug. Oral. Safest and most common, convenient and economical route of administration. Disadvantages include limited absorption of some drugs, food may affect absorption, patient compliance is necessary, drugs may be metabolized before systemic absorption. Examples include acetaminophen tablets, amoxicillin suspension. Sublingual. Bypasses first pass effect, bypasses destruction by stomach acid, drug solubility maintained because the pH of saliva relatively neutral, may cause immediate pharmacological effects. Limited to certain types of drugs, limited drugs that can be taken in small doses may lose part of the drug dose if swallowed. Examples include nitroglycerin, buprenorphine. Intravenous can have immediate effects, ideal if dosed in large volumes, suitable for irritating substances and complex mixtures, valuable in emergency situations, dosage titration permissible, idea for high molecular weight proteins and peptide drugs. Unsuitable for oily substances, bolus injection may result in adverse effects, most substances must be slowly injected, strict aseptic techniques needed. Examples include vancomycin, heparin. Intramuscular, suitable if drug volume is moderate, suitable for oily vehicles and certain irritating substances, preferable to intravenous if patients must self-administer. Affect certain lab tests, creatine kinase, can be painful, can cause intramuscular hemorrhage, precluded during anticoagulation therapy. Examples include haloperidol, depot, progesterone. Subcutaneous, suitable for slow-release drugs, ideal for some poorly soluble suspensions, pain or necrosis if drug is irritating, unsuitable for drugs administered in large volumes. Examples include epinephrine, insulin, heparin. Inhalation, absorption is rapid, can have immediate effects, ideal for gases, effective for patients with respiratory problems, dose can be titrated, localized effect to target lungs, lower doses used compared to that with oral or parenteral administration, fewer systemic side effects. Most addictive truth, drug can enter the brain quickly. Patient may have difficulty regulating dose. Some patient may have difficulty using inhalers. Examples include albuterol, fluticasone. Topical, suitable when local effect of drug is desired, may be used for skin, eye, intravaginal and intranasal products, minimizes systemic absorption, is for patient. Disadvantages include some systemic absorption can occur, unsuitable for drugs with high molecular weight or poor lipid solubility. Examples include clotrimazole cream, hydrocortisone cream, timolol eye drops. Transdermal patch bypasses the first pass effect, convenient and painless, ideal for drugs that are lipophilic and have poor oral bioavailability, ideal for drugs that are quickly eliminated from the body. Some patients are allergic to patches, which can cause irritation. Drug must be highly lipophilic, may cause delayed delivery of drug to pharmacological site of action, limited drugs that can be taken in small daily doses. Examples include nitroglycerin, nicotine, scopolamine. Rectal, partially bypasses first pass effect, bypasses destruction by stomach acid, ideal if drug causes vomiting, ideal in patients who are vomiting or comatose. Drugs may irritate the rectal mucosa, not a well accepted route. Examples include biascodyl, promethazine. This is another figure which can be seen. There is a route, advantage and disadvantage. Let's see. Oral, convenient, relatively safe and economical, cannot be used for drugs that are inactivated by gastric acid, for drugs with a large first pass effect, or for drugs that irritate the gut. Intramuscular, suitable for suspensions and oily vehicles, absorption is rapid from solutions and slow and sustained from suspensions, may be painful, can cause bleeding if patient is receiving an anticoagulant. Subcutaneous, suitable for suspensions and pellets, absorption similar to that in the intramuscular route, but is usually somewhat slower. Cannot be used for drugs that irritate cutaneous tissues or for drugs that must be given in large volumes. Intravenous bypasses absorption to give an immediate effect, allows for rapid titration drug, achieves 100% bioavailability, poses more risk for toxicity and tends to be more expensive than other routes. Pharmacokinetics versus pharmacodynamics. Pharmacokinetics refers to what it does to a drug. So drug will be administered, then absorption, drug distributed in tissues, drugs come in circulation, drugs at site of action, clinical effects, drug response curves will be prepared, and then drug metabolized and excreted. Pharmacodynamics describe what the drug does to the body. Let's start with pharmacokinetics. A, D, and E. A for absorption, D for distribution, M for metabolism, E for elimination. First, absorption from the site of administration permits entry of drug either directly or indirectly into plasma. Second, drug may irreversibly leave bloodstream and distribute into interstitial and intracellular fluids. Third, drug may be biotransformed through metabolism by liver or other tissues. Finally, drug and its metabolites are eliminated from body in urine, bile, or feces. Using knowledge of pharmacokinetic parameters, that is, absorption, distribution, metabolism, and elimination, clinicians can design optimal drug regimens, including route of administration, dose, frequency, and duration of treatment. Drug absorption. Absorption is drug transfer from administration site to bloodstream. Rate and extent of absorption depends on environment where drug is absorbed, chemical characteristics of drug, and route of administration. Influences bioavailability. Routes of administration other than intravenous may result in partial absorption and lower bioavailability. Mechanisms of absorption of drugs from gastrointestinal tract. Depending on their chemical properties, drugs may be absorbed from gastrointestinal tract by passive diffusion, facilitated diffusion, active transport, or endocytosis. Passive diffusion. Vast majority of drugs are absorbed by this mechanism. Driving force for drug passive diffusion is concentration gradient across membrane separating two body compartments. Drug moves from an area of high concentration to one of lower concentration. Passive diffusion doesn't involve a carrier, is not saturable, and shows low structural specificity. Water-soluble drugs penetrate cell membrane through aqueous channels or pores, whereas lipid-soluble drugs readily move across most biologic membranes due to solubility in membrane lipid bilayers. Facilitated diffusion. Other agents can enter cell through specialized transmembrane carrier proteins that facilitate passage of large molecules. These carrier proteins undergo conformational changes, allowing passage of drugs or endogenous molecules into interior of cells. This process is known as facilitated diffusion. It doesn't require energy, can be saturated, and may be inhibited by compounds that compete for carrier. We can see in the figure 1, passive diffusion of water-soluble drug through an aqueous channel or pore. Passive diffusion of a lipid-soluble drug dissolved in a membrane. Figure 2 shows facilitated diffusion. Active transport. This mode of drug entry also involves specific carrier proteins that span membrane. However, active transport is energy dependent, driven by hydrolysis of adenosine triphosphate. It is capable of moving drugs against a concentration gradient from region of low drug concentration to one of higher concentration. This process is saturable. Active transport systems are selective and may be competitively inhibited by other co-transported substances. Endocytosis and exocytosis. This type of absorption is used to transport drugs of exceptionally large size across cell membrane. Endocytosis involves engulfment of a drug by cell membrane and transport into cell by pinching of drug-filled vesicle. Vitamin B12 is transported across gut wall by endocytosis. Exocytosis is reverse of endocytosis. Many cells use exocytosis to secrete substances out of cell through similar process of vesicle formation. Certain neurotransmitters, for example, norepinephrine, are stored in intracellular vesicles in nerve terminal and released by exocytosis. Factors influencing absorption. Effect of pH on drug absorption. Most drugs are either weak acids or weak bases. Acidic drugs release a proton, causing a charged anion to form, as shown in figure A. Weak bases can also release an proton. However, the protonated at form of basic drug is usually charged, and loss of a proton produces uncharged base, as shown in figure B. Drug passes through membranes more readily if it is uncharged. Therefore, effective concentration of permeable form of each drug at its absorption site is determined by relative concentrations of charged and uncharged forms. Ratio between two forms is in turn determined by pH at absorption site and by strength of weak acid or base, which is represented by ionization constant pKa. pKa is a measure of strength of interaction of a compound with a proton. Lower pKa, more acidic is drug. Higher pKa, more basic is drug. Distribution equilibrium is achieved when permeable form of drug achieves an equal concentration in all body water spaces. Blood flow to absorption site. Intestines receive much more blood flow than does stomach. So absorption from intestine is favored over stomach. Shock severely reduces blood flow to cutaneous tissues, thereby minimizing absorption from subcutaneous administration. Total surface area available for absorption. With a surface rich in brush borders containing microvilli, intestine has a surface area about 1000-fold that of stomach, making absorption of drug across intestine more efficient. Contact time at absorption surface. If a drug moves through gastrointestinal tract very quickly, as can happen with severe diarrhea, it is not well absorbed. Anything that delays transport of the drug from stomach to intestine delays absorption. Presence of food in stomach both dilutes drug and slows gastric emptying. Therefore, drug taken with a meal is generally absorbed more slowly. Expression of P-glycoprotein. P-glycoprotein is a transmembrane transporter protein responsible for transporting various molecules, including drugs, across cell membranes. Figure shows 6 membrane spanning loops of P-glycoprotein from a central channel for ATP-dependent pumping of drugs from cell. It is expressed in tissues throughout body, including liver, kidneys, placenta, intestines, and brain capillaries, and is involved in transportation of drugs from tissues to blood. That is, it pumps drugs out of cells. Thus, in areas of high expression, P-glycoprotein reduces drug absorption. In addition to transporting many drugs out of cells, it is also associated with multi-drug resistance. Bioavailability is rate and extent to which an administered drug reaches systemic circulation. For example, if 100 mg of a drug is administered orally and 70 mg is absorbed unchanged, the bioavailability is 0.7 or 70%. Determining bioavailability is important for calculating drug dosages for non-intravenous routes of administration. Determination of bioavailability. Bioavailability is determined by comparing plasma levels of drug after a particular route of administration, for example, oral administration, with levels achieved by intravenous administration. After intravenous administration, 100% of drug rapidly enters circulation, as can be shown with the blue color in the graph. When drug is given orally, as shown with the red color in the graph, only part of administered drug dose appeared in plasma. By plotting plasma concentration of drug versus time, area under curve, AUC, can be measured. Factor that influence bioavailability. In contrast to intravenous administration, which confers 100% bioavailability, orally administered drugs often undergo first-pass metabolism. This biotransformation, in addition to chemical and physical characteristics of drugs, determines rate and extent to which agent reaches systemic circulation. First-pass hepatic metabolism. When a drug is absorbed from gastrointestinal tract, it enters portal circulation. Before entering systemic circulation, if drug is rapidly metabolized in liver or gut wall, during this initial passage, amount of uncharged drug entering systemic circulation is decreased. This is referred as first-pass metabolism. First-pass metabolism by intestine or liver limits efficacy of many oral medications. For example, more than 90% of nitroglycerin is cleared through first-pass metabolism. Hence, it is primarily administered via sublingual, transdermal, or intravenous route. Drugs with high first-pass metabolism should be given in doses sufficient to ensure that enough active drug reaches desired site of action. Drug solubility. Very hydrophilic drugs are poorly absorbed because of inability to cross lipid-rich cell membranes. Paradoxically, drugs that are extremely lipophilic are also poorly absorbed because they are insoluble in aqueous body fluids and therefore cannot gain access to surface of cells. For a drug to be rapidly absorbed, it must be largely lipophilic, yet have some solubility in aqueous solutions. This is one reason why many drugs are either weak acids or weak bases. Chemical instability. Some drugs, such as penicillin G, are unstable in pH of gastric contents. Others, such as insulin, are destroyed in gastrointestinal tract by degradative enzymes. Nature of drug formulation. Drug absorption may be altered by factors unrelated to drug chemistry. For example, particle size, salt form, crystal polymorphism, enteric coating, and presence of excipients such as binders and dispensing agents can influence the ease of its dissolution and therefore alter the rate of absorption. Bioequivalence and other types of equivalence. Two drug formulations are bioequivalent if they show comparable bioavailability and similar times to achieve peak blood concentrations. Two drug formulations are therapeutically equivalent if they are pharmaceutically equivalent. That is, they have same dosage form, contain same active ingredient, at same strength, and use same route of administration with similar clinical and safety profile. Thus, therapeutic equivalence requires that drug products are bioequivalent and pharmaceutically equivalent. This figure shows that pharmaceutical equivalent are same active ingredient, same dosage form, same route of administration, same dose, complies with the same compendial United States pharmacopoeia requirements, may be different shape, scoring, excipient. Therapeutic equivalent, same clinical effect, same safety profile. Bioequivalent products, same rate and event of bioavailability. Pharmaceutical alternative, same therapeutic moiety, different salts, ester, complexes, different dosage forms, different strengths. Drug distribution. Drug distribution is process by which drug reversibly leaves bloodstream and enters extracellular fluid and tissues. For drug administered intravenous, absorption is not a factor. An initial phase immediately following administration represents distribution phase, during which drug rapidly leaves circulation and enters tissues. Drug distribution from plasma to interstitium depends on cardiac output and local blood flow, capillary permeability, tissue volume, degree of drug binding to plasma and tissue proteins, and relative drug lipophilicity. Blood flow. Rate of blood flow to tissue capillaries varies widely. Blood flow to vessel-rich organs like brain, liver, kidney is greater than that to skeletal muscles. Adipose tissue, skin, and viscera have still lower rates of blood flow. Variation in blood flow partly explains the short duration of hypnosis produced by an intravenous bolus of propofol. High blood flow together with high lipophilicity of propofol permits rapid distribution into central nervous system and produces anesthesia. A subsequent slower distribution to skeletal muscle and adipose tissue lowers plasma concentration so that drug diffuses out of central nervous system, down concentration gradient, and consciousness is regained. Capillary permeability is determined by capillary structure and by drug chemical nature. Capillary structure varies in terms of fraction of basement membrane exposed by slit junctions between endothelial cells. In liver and spleen, a significant portion of basement membrane is exposed due to large, discontinuous capillaries through which large plasma proteins can pass. In brain, capillary structure is continuous and there are no slit junctions. To enter brain, drugs must pass through endothelial cells of central nervous system, capillaries, or undergo active transport. For example, a specific transporter carries levodopa into brain. Lipid-soluble drugs readily penetrate central nervous system because they dissolve in endothelial cell membrane. By contrast, ionized or polar drugs generally fail to enter central nervous system because they cannot pass through endothelial cells that have no slit junction. They closely juxtapose cells from tight junctions that constitute blood-brain barrier as shown in figure C. So figure A, structure of liver capillary, large fenestrations allow drugs to move between blood and interstitium in the liver, drug, endothelial cell, slit junction, basement membrane. B, structure of brain capillary, astrocyte food processes, basement membrane, brain and endothelial cells. At tight junctions, two conjoining cells merge so that the cells are physically joined and form a continuous wall that prevents many substances from entering the brain. C, permeability of a brain capillary. Charged drug, lipid-soluble drugs carry immediate transport. Binding of drugs to plasma proteins and tissues. Binding to plasma proteins. Reversible binding to plasma proteins sequesters drugs in a non-diffusible form and slows transfer out of the vascular compartment. Albumin is major drug binding protein, and it may act as a drug reservoir. As concentration of free drug decreases due to elimination, bound drug dissociates from albumin. This maintains free drug concentration as a constant fraction of total drug in plasma. Binding to tissue proteins. Many drugs accumulate in tissues, leading to higher concentration in tissues than in interstitial fluid and blood. Drugs may accumulate because of binding to lipids, proteins, or nucleic acids. Drugs may also undergo active transport into tissues. These reservoirs may serve as a major drug source and prolong its actions or cause local drug toxicity. Acrolein, metabolite of cyclophosphamide, can cause hemorrhagic cystitis because it accumulates in bladder. Lipophilicity. Drug chemical nature strongly influences its ability to cross cell membranes. Lipophilic drugs readily move across most biologic membranes. These drugs dissolve in lipid membranes and penetrate entire cell surface. Major factor influencing the distribution of lipophilic drugs is blood flow to area. By contrast, hydrophilic drugs do not readily penetrate cell membranes and must pass through slit junctions. Volume of distribution. Apparent volume of distribution, that is VD, is defined as fluid volume that is required to contain entire drug in body at same concentration measured in plasma. It is calculated by dividing dose that ultimately gets into the systematic circulation by plasma concentration at time 0. Although VD has no physiologic or physical basis, it can be useful to compare drug distribution with volumes of water compartments in body. Distribution into water compartment in body. Once a drug enters body, it has potential to distribute into any one of three functionally distinct compartments of body water or to become sequestered in a cellular site. Plasma compartment. If drug has high molecular weight or is extensively protein bound, it is too large to pass through slit junctions of capillaries and is effectively trapped within plasma. That is vascular compartment. As a result, it has low apparent volume of distribution that approximates plasma volume or about 4 liter in a 70 kilogram individual. Heparin shows this type of distribution. Extracellular fluid. If drug has low molecular weight but is hydrophilic, it can pass through endothelial slit junctions of capillaries into interstitial fluid. However, hydrophilic drugs cannot move across lipid membranes of cells to enter intercellular fluid. Therefore, these drugs distribute into a volume that is sum of plasma volume and interstitial fluid, which together constitute extracellular fluid. About 20% of body weight or 14 liter in a 70 kg individual. Aminoglycoside antibiotics show this type of distribution. Total body weight. If drug has low molecular weight and has enough lipophilicity, it can move into interstitium through slit junctions and pass through cell membranes into intercellular fluid. These drugs distribute into a volume of about 60% of body weight or about 42 liter in a 70 kg individual. Ethanol exhibits this apparent volume of distribution. A larger volume of distribution indicates greater distribution in tissues. A smaller apparent volume of distribution suggests confinement to plasma or extracellular fluid. Determination of volume of distribution. Drug clearance is usually first order process allows calculation of volume of distribution. First order means that constant drug fraction is eliminated per unit of time. This process can be most easily analyzed by plotting log of plasma drug concentration versus time as shown in figure A. Plasma drug concentration can be extrapolated back to time 0, time of intravenous bolus, or y-axis to determine C0, which is drug concentration that would have been achieved if distribution phase had occurred instantly. This allows calculation of volume distribution as Vd is equal to dose divided by C0. If 10 milligram of drugs is injected into patient and plasma concentration is extrapolated back to time 0 and C0 is 1 milligram per liter from graph B in figure B, then volume distribution is equal to 10 milligram per 1 milligram per liter is equal to 10 liters. Effect of volume distribution on drug half-life. Volume of distribution has an important influence on drug half-life because drug elimination depends on drug amount delivered to liver or kidney or other organs where metabolism occurs per unit of time. Delivery of drug to organs of elimination depends not only on blood flow but also on fraction of drug in plasma. If drug has large volume distribution, most of drug is in extraplasmic space and is unavailable to excretory organs. Therefore, any factor that increases volume distribution can increase half-life and extend duration of drug action. An exceptionally large volume distribution indicates considerable sequestration of drug in some tissues or compartments. Drug clearance through metabolism. Once a drug enters body, process of elimination begins. Three major routes of elimination are hepatic, biliary, and elimination and urinary excretion. Elimination is irreversible removal of drug from body and involves biotransformation, that is drug metabolism and excretion. Excretion is removal of intact drug from body. Together, these elimination processes decrease plasma concentration exponentially. That is, a constant fraction of drugs eliminated in a given unit of time, shown in figure. Metabolism results in products with increased polarity, which allows drug to be eliminated. Clearance estimates volume of blood from which drug is cleared per unit of time. Total clearance is composite estimate reflecting all mechanism of drug elimination and is calculated as follows. Where this is the elimination half-life, VD is apparent volume distribution, and 0.693 is natural log constant. Drug half-life is often used as a measure of drug clearance because many drugs volume with distribution is constant. Kinetics of metabolism. First order kinetics, linear kinetics. Metabolic transformation of drugs is catalyzed by enzymes and most of reactions obey Michaelis-Menten kinetics, where Km is Michaelis constant, substance concentration and half maximal velocity. Most clinical situation, drug concentration C is much less than Michaelis constant Km, and Michaelis-Menten equation reduces to rate of drug metabolism is equal to Vmax C divided by Km. Rate of drug metabolism and elimination is directly proportional to free drug concentration, and first order kinetics is observed. As shown in figure. So, with a few drugs such as aspirin, ethanol, phenytoin, doses are very large. Therefore, the plasma drug concentration is much greater than Km, and drug metabolism is zero order. That is constant and independent of the drug dose. With most drugs, the plasma drug concentration is less than Km, and drug elimination is first order. That is proportional to drug dose. So, this means constant drug fraction is metabolized per unit of time. That is, with each half-life, concentration decreases by 50%. Zero order kinetics, non-linear kinetics. With a few drugs such as aspirin, ethanol, and phenytoin, as mentioned previously, doses are very large. Therefore, C is much greater than Km, and velocity equation becomes rate of drug metabolism is equal to V max C divided by C, and is equal to V max only. Enzyme is saturated by high free drug concentration, and metabolism rate remains constant over time. This is called zero order kinetics. Constant drug amount is metabolized per unit of time. Rate of elimination is constant, and dose does not depend on drug concentration. Reactions of drug metabolism. Kidney cannot efficiently excrete lipophilic drugs that readily cross cell membrane that are reabsorbed in distal convoluted tubules. Therefore, lipid-soluble agents are first metabolized into more polar hydrophilic substances in liver via two general sets of reactions called phase 1 and phase 2. Xenobiotic metabolizing enzymes. Enzymes, phase 1, oxygenases, cytochrome P450s, flavin-containing monooxygenases, epoxide hydrogenases, C and O oxygenation, dealkalization, others, and nitrogen, sulfur, and phosphorylation, oxidation, hydrolysis of epoxides, phase 2 transferases, sulfur transferases, addition of sulfate, UDP, gluconosyl transferases, addition of glucuronic acid, glutathione S transferases, addition of glutathione, and acetyl transferases, addition of acetyl group, methyl transferases, addition of methyl group, other enzyme, alcohol dehydrogenase, reduction of alcohols, aldehyde hydrogenases, reduction of aldehydes, reduce nicotinamide adenosine, dinucleotide phosphate, quinone, oxidoreductase, reduction of quinones. Phase 1. Phase 1 reactions convert lipophilic drugs into more polar molecules by introducing or unmasking polar functional group such as OH or NH2. Phase 1 reaction usually involves reduction, oxidation, or hydrolysis. Phase 1 metabolism may increase, decrease, or have no effect on pharmacological activity. Phase 1 reaction utilizing P450 system. Phase 1 reactions involved in drug metabolism are catalyzed by cytochrome P450 system. P450 system is important for metabolism of many endogenous compounds, for example, steroids, lipids, and for biotransformation of exogenous substances, drugs, carcinogens, and environmental pollutants. Cytochrome is a superfamily of heme-containing isozymes located in most cells, but primarily in liver and gastrointestinal tract. 57 functional cytochrome genes and 58 pseudogenes in humans are available. Genes are grouped into families and subfamilies. Nomenclature. CYP are named with root CYP followed by number designated family as there are 3, letter denoting subfamily as A, and second number designated CYP isoform as 4 gene number. Specificity: 4 isozyme CYP3A, 4 and 5, CYP2D6, CYP2C8 or 9, and CYP182 are responsible for vast majority of P450 catalyzed reactions. Considerable amounts of CYP3A4 are found in intestinal mucosa, accounting for first-pass metabolism of drugs such as chlorpromazine and clonazepam. Genetic variability. P450 enzyme exhibit considerable genetic variability among individuals and racial groups. Variations in P450 activity may alter drug efficacy and risk of adverse events. CYP2D6 in particular exhibit genetic polymorphism. CYP2D6 mutations results in very low capacities to metabolize substrate. For example, some individuals obtain no benefit from opioid analgesic codeine because they lack CYP2D6 enzyme that activates drug. Similar polymorphism have been characterized for CYP2C subfamily of isoenzyme. For example, clopidogrel carries a warning that patients who are CYP2C19 poor metabolizers have diminished antiplatelet effect when taking this drug, and alternative mitigation should be considered. Clopidogrel is product, and CYP219 activity is required to convert it to active metabolite. CYP inducers. CYP450 independent enzymes are important target for pharmacokinetic drug interactions. For example, phenobarbital, rifampin, and carbamazepine are capable of inducing CYP isozymes. These results in increased biotransformation of drugs and can lead to significant decreases in plasma concentration of drugs metabolized by these cytochrome isozymes, often with concurrent loss of pharmacologic effect. For example, rifampin, an anti-tuberculosis drug, significantly decreased plasma concentrations of human immunodeficiency virus protease inhibitors, thereby diminishing ability to suppress HIV replications. The figure shows some of more important inducers for representative CYP isozyme. CYP inhibitors. Inhibition of drug metabolism can lead to significant increase in the plasma drug concentration and resultant adverse effects on drug toxicity. Most common form of inhibition is through competition for same isozyme. Some drugs, however, are capable of inhibiting reaction for which they are not substrate. For example, ketoconazole, leading to drug interactions. Numerous drugs inhibit one or more CYP-dependent biotransformation pathways of warfarin. For example, omeprazole is potent inhibitor of 3 CYP isozymes involved in warfarin metabolism. When taken with omeprazole, plasma concentrations of warfarin increase, which leads to greater anticoagulant effect and increased risk of bleeding. Most important CYP inhibitors are erythromycin, ketoconazole, and ritonavir because they inhibit several CYP isozymes. Phase 1 reaction not involving P450 system. These include amine oxidation, oxidation of catecholamines or histamine, alcohol dehydrogenation, for example, ethanol oxidation, esterases, for example, metabolism of aspirin in liver, and hydrolysis of procaine. Phase 2. This phase consists of conjugation reaction. If metabolite from phase 1 is sufficiently polar, it can be excreted by kidney. However, many phase 1 metabolites are still too lipophilic to be excreted. Subsequent conjugation reaction with endogenous substrates such as glucuronic acid, sulfonic acid, acetic acid, or amino acid results in polar, usually more water-soluble compounds that are often therapeutically inactive. A notable exception is morphine 6-glucuronide, which is more potent than morphine. Glucuronidation is most common and important conjugation reaction. Drugs already possessing an OH, NH2, or COH group may enter phase 2 directly and become conjugated without prior phase 1 metabolism. Highly polar drug conjugates are then excreted by kidney or in bile. Drug clearance by kidney. Drugs must be sufficiently polar to be eliminated from body. Drug removal from body occurs by a number of routes. Most important is elimination through kidney into urine. Patients with renal dysfunction may be unable to excrete drugs and are at risk for drug accumulation and adverse effects. Drug renal elimination. Drug passes through several processes in kidney before elimination: glomerular filtration, active tubular secretion, and passive tubular reabsorption. Let's see glomerular filtration. Drugs enter kidney through renal arteries, which divide to form glomerular capillary plexus. Free drug not bound to albumin flows through capillary slits into Bowman space as part of glomerular filtrate. Glomerular filtration rate is normally about 120 milliliter per minute per 1.73 meter square, but may diminish significantly in renal disease. Lipid solubility and pH do not influence drugs passage into glomerular filtrate. However, variations in glomerular filtration rate and protein binding of drugs do affect this process. Proximal tubular secretion. Drugs that were not transferred into glomerular filtrate leave glomeruli through afferent arterioles which divide to form a capillary plexus surrounding nephric lumen in proximal tubule. Secretion primarily occurs in proximal tubules by two energy requiring active transport system, one for anions, for example, deprotonated forms of weak acid, and one for cations, for example, protonated forms of weak bases. Each of these transport systems shows low specificity and can transport many compounds. Thus, competition between drugs for these carriers can occur within each transport system. Premature infants and inuits have an incompletely developed tubular security mechanism and thus may retain certain drugs in blood. Distal tubular reabsorption. A drug moves toward distal converted tubule, its concentration increases and exceeds that of perivascular space. Drug, if uncharged, may diffuse out of nephric lumen back into systemic circulation. Manipulating urine pH to increase fraction of ionized drug in lumen may be done to minimize amount of back diffusion and increased clearance of undesirable drug. Generally, weak acids can be eliminated by urine alkalization, where elimination of weak bases may be increased by urine acidification. This process is called ion trapping. For example, a patient presenting with phenobarbital weak acid overdose can be given bicarbonate, which alkalinizes urine and keeps drug ionized, thereby decreasing its reabsorption. Excretion by other routes. Drug excretion may also occur via intestine, bile, lungs, and breast milk, among others. Drugs that are not absorbed after oral administration or drugs that are excreted directly into intestine or into bile are excreted in feces. Lungs are primarily involved in elimination of anesthetic gases, for example, desflurane. Drug elimination in breast milk may expose breastfeeding infant to medications and or metabolites being taken by mother and the potential source of undesirable side effects to infant. Excretion of most drugs into sweat, saliva, tears, hair, skin occurs only to a small extent. Total body clearance and drug half-life are important measures of drug clearance that are used to optimize drug therapy and minimize toxicity. Total body clearance. Total body systemic clearance is sum of all clearances from drug metabolizing and drug eliminating organs. Kidney is often major organ of excretion. Liver also contributes to drug clearance through metabolism and or excretion into bile. Total clearance is calculated using following equation. Total clearance is equal to hepatic clearance, renal clearance, pulmonary clearance, and other clearance, where hepatic and renal are typically the most common and important drug clearance. Clinical situations resulting in changes in drug half-life. When patient has abnormality that alters drug half-life, adjustment in dosage is required. Patients who may have increase in drug half-life include those with diminished renal or hepatic blood flow, for example, in cardiogenic shock, heart failure, or hemorrhage. Decreased ability to extract drug from plasma, for example, in renal disease. Decreased metabolism, for example, when a concomitant drug inhibits metabolism, or in hepatic insufficiency as cirrhosis. These patients may require a decrease in dosage or less frequent dosing intervals. In contrast, drug half-life may be decreased by increased hepatic blood flow, decreased protein binding, or increased metabolism. This may necessitate higher doses or may frequent dosing intervals. Design and optimization of dosage regimen. To initiate drug therapy, clinician must select appropriate route of drug administration, dosage, and dosing interval. Selection of regimen depends on various patient and drug factors, including how rapidly therapeutic drug levels must be achieved. Therapy may consist of single drug dose, for example, sleep-inducing agent such as zolpidem. More commonly, drugs are continuously administered either as intravenous infusion or in intravenous oral fixed dose, fixed time interval regimens. For example, one tablet every 4 hours. Continuous or repeated administration results in drug accumulation until steady state occurs. Steady state concentration is reached when rate of drug elimination is equal to rate of drug administration, such that plasma and tissue levels remain relatively constant. Continuous infusion regimens. With continuous intravenous infusion, rate of drug into body is constant. Most drugs exhibit first order elimination. That is, constant drug fraction is cleared per unit of time. Therefore, rate of drug elimination increases proportionately as plasma concentration increases. Plasma concentration of drug following continuous intravenous infusion. Following initiation of continuous intravenous infusion, plasma drug concentration rises until steady state rate of drug elimination equals rate of drug administration is reached, at which point plasma drug concentration remains constant. Influence of infusion rate or steady state concentration. Steady state plasma concentration is directly proportional to infusion rate. If infusion rate is doubled, steady state plasma concentration is double. If steady state plasma concentration is inversely proportional to drug clearance, any factor that decreases clearance, such as liver or kidney disease, increases steady state plasma concentration of an infused drug, assuming apparent volume of distribution remains constant. Factors that increase clearance, such as increased metabolism, decrease steady state plasma concentration. Time to reach steady state drug concentration. Drug concentration rises from 0 at start of infusion to its ultimate steady state level. Steady state plasma concentration, rate constant for attainment of steady state is rate constant for total body drug elimination. 50% of steady state drug concentration is observed after time lapse, since infusion is equal to half-life, where half-life is time required for drug concentration to change by 50%. After another half-life, drug concentration approaches 75% of steady state plasma concentration. Drug concentration is 87.5% of steady state plasma concentration at 3 half-lives and 90% at 3.3 half-lives. Thus, drug reaches steady state in about 4 to 5 half-lives. Sole determinant of rate that drug achieves steady state in half-life of drug, and this head rate is influenced only by factors that affect half-life. Rate of steady state is not affected by rate of infusion. When infusion is stopped, plasma concentration of drug declines, wash out to 0 with same time course observed in approaching steady state. As shown in this figure, 50% of steady state drug concentration is achieved in half-life. 90% of the steady state drug concentration is achieved in 3.3 half-lives. The washout of the drug is exponential with the same time constant as that during drug infusion. For example, drug concentration declines 50% of the steady state level in half-life. Fixed dose, fixed time regimens. Drug administration by fixed doses rather than by continuous infusion is often more convenient. However, fixed doses of intravenous or oral medications given at fixed intervals result in time-dependent fluctuations in circulating drug level, which contrasts with smooth ascent of drug concentration with continuous infusion. Multiple intravenous injections. When drug is given repeatedly at regular intervals, plasma concentration increases until a steady state is reached, as shown in figure. So here is plasma concentration of drug in body with time. Because most drugs are given at intravenous intervals shorter than 5 half-lives and are eliminated exponentially with time, some drug from first dose remains in body when second dose is administered. Some from second dose remains when third dose is given, and so forth. Therefore, drug accumulates until within dosing interval, rate of drug elimination equals to rate of drug administration and a steady state is achieved, as black can be seen. So injection of 2 units of drug once or daily, that's shown in red color. Injection of 1 unit of drug twice daily, shown in blue color, but we need the black color. So as we see that drug accumulates until dosing interval, rate of drug elimination equals rate of drug administration and the steady state is achieved. Effect of dosing frequency. With repeated administration at regular intervals, plasma drug concentration oscillates, as I already show you the blue and red color. About a mean. Using smaller doses at shorter intervals reduces amplitude of fluctuation in drug concentration. However, dosing frequency changes neither magnitude of steady state plasma concentration nor the rate of achieving the steady state plasma concentration. Example of achievement of steady state using different dosage regimens. Curve B of figure shows drug amount in a body when 1 unit of a drug is administered intravenous and repeated at a dosing interval that corresponds to drug half-life. At the end of first dosing interval, 0.5 units of drug remain from first dose when second dose is administered. At the end of second dose, 0.75 units are present when third dose is given. Minimum amount of drug remaining during dosing interval progressively approaches a value of 1 unit, whereas maximum value immediately following drug administration progressively approaches 2 units. Therefore, at steady state, 1 unit of drug is lost during dosing interval, which is exactly matched by rate of administration. That is, rate in equals rate out. As in case for intravenous infusion, 90% of steady state value is achieved in 3.3 half-lives. Multiple oral administrations. Most drugs administered on outpatient basis are oral medication taken at specific dose 1, 2, or more times daily. In contrast to intravenous injection, orally administered drugs may be absorbed slowly, and plasma drug concentration is influenced by both absorption rate and emission rate as shown in figure. So, again, y-axis we have plasma concentration of drug, and x-axis we have a time. The red color shows repeated fixed dose. Repeated oral administration of a drug results in oscillation in plasma concentration that are influenced by both the rate of drug absorption and the rate of drug elimination. The blue color shows single fixed dose. A single fixed dose of drug given orally represents in a single peak in plasma concentration followed by a continuous decline in drug level. So there is an increase and there is a continuous decline in drug level. Optimization of dose. Goal of drug therapy is to achieve and maintain concentrations within a therapeutic response window while maximizing toxicity and/or adverse effects. With careful titration, most drugs can achieve this goal. If drug therapeutic window is small, for example, dioxin or lithium, extra caution should be taken in selecting a dosage regimen, and drug levels should be monitored to ensure attainment of therapeutic range. Drug regimens are administered as a maintenance dose and may require loading dose if rapid effects are warranted. So let's see what is meant by maintenance dose. Drugs are generally administered to maintain a steady state plasma concentration within therapeutic window. It takes 4 to 5 half-lives for drug to achieve steady state plasma concentration. To achieve a given concentration, administration rate and elimination rate of drug are important. Dosing rate can be determined by knowing target plasma concentration, that is CP, drug clearance, that is CL, from systemic circulation, and fraction absorbed, that is bioavailability. Using this equation, we can calculate the dosing rate. Loading dose. Sometimes rapid obtainment of desired plasma levels is needed, for example, in serious infections or arrhythmias. Therefore, drug loading dose is administered to achieve desired plasma level rapidly, followed by a maintenance dose to maintain the steady state. As we can see, again, y-axis we have a drug concentration in plasma, x-axis we have a time. So, with loading dose, blue color, without loading dose is a red color, and dosing started here. So, loading dose, the formula will be volume of distribution multiplied by desired steady state plasma concentration divided by F or bioavailability. Disadvantages of loading doses include increased risk of drug toxicity and long time for plasma concentration to fall if excess levels occurs. Dose adjustment. Amount of drug administered for a given condition is estimated based on average patient. Monitoring drug therapy and correlating it with clinical benefits provides another tool to individualize therapy. For drugs with defined therapeutic range, drug concentrations are measured and dosage and frequency are adjusted to obtain desired levels. When administering a dosage adjustment, volume distribution can be used to calculate the amount of drug needed to achieve a set desired plasma concentration. Assume heart failure patient is not well controlled due to inadequate plasma levels of digoxin. Suppose digoxin plasma concentration is C1 and desired target concentration is C2, higher concentration. Following calculation can be used to determine how much additional digoxin should be administered to bring level from C1 to C2. So C1, drug amount initially in body, C2, drug amount in body needed to achieve desired plasma concentration. So the difference between two values is additional dose is needed, which equals VD C2 minus C1. So we can see the plasma concentration during oral therapy fluctuate around the steady state level obtained with intravenous therapy. Dose is doubled in this case and dose is half in this case. When doses are doubled, halved, or stopped during steady state administration, the time required to achieve a new steady state level is independent of the route of administration. Pharmacodynamics. Describe drug actions on body. Most drugs exert effects both beneficial and harmful by interacting with specialized target macromolecules called receptors, which are present on or in cell. Drug receptor complex initiate alteration in biochemical or and molecular activity of cell by a process called signal transduction. Signal transduction is drugs act as signals and receptors act as signal detectors. So again, drugs act as signals and receptors act as signal detectors. Drug is termed as agonist if it binds to a site on receptor protein and it activates it to initiate series of actions that ultimately results in specific intercellular response. Second messenger or effector molecules are part of cascade of events that translate agonist binding into cellular response. So, drug receptor complex. The cells have many different types of receptors, each of which is specific for particular agonist and produces unique response. For example, cardiac cell membrane contain beta-adrenergic receptors that bind and respond to epinephrine or norepinephrine. Cardiac cells also contain muscarinic receptors that bind and respond to acetylcholine. These two receptor populations dynamically interact to control heart's vital functions. Magnitude of cellular response is proportional to number of drug receptor complexes. This concept is conceptually similar to formation of complexity between enzyme and substrate and shares many common features such as receptor specificity for a given agonist. It is important to know that not all drugs exert effects by interacting with the receptor. And acids, for instance, chemically neutralize excess gastric acid, thereby reducing stomach upset. In one, unoccupied receptor does not influence intercellular processes. In two, receptor with bound agonist is activated. It has altered physical and chemical properties, which leads to interaction with cellular molecule to cause a biological response. So this is receptor, activity receptor, signal transduction, and we have a biological response. Receptor states. Receptors exist in at least two states, inactive or asterisk, that are irreversible equilibrium with one another, usually favoring inactive state. Binding of agonists causes equilibrium to shift from inactive to active to produce a biologic effect. Antagonists are drugs that bind to receptor but not increase fraction of active, instead stabilizing fraction of inactive. Some drugs, partial agonists, shift equilibrium from inactive to active, but fraction of active is less than caused by agonists. Magnitude of biological effect is directly related to fraction of active. In summary, agonists, antagonists, partial agonists are examples of molecules or ligands that bind to activation site on receptor and can affect fraction of active receptor state. Drug effects are produced by altering normal functions of cells and tissue in body via one of four general mechanisms: interaction with receptors, alteration of enzyme activity, antimetabolite action, non-specific chemical or physical interactions. Interaction with receptor include ligand-activated ion channels, G-protein coupled receptors, receptor-activated tyrosine kinase, intercellular nuclear receptors. G-protein coupled receptors include G-alpha stimulatory coupled receptors, G-alpha inhibitory coupled receptors, GQ and G11 coupled receptors. Now we will describe and explain these major receptor families. So first, what is receptor? Receptor is defined as any biologic molecule to which drug binds and produces measurable response. Enzymes, nucleic acids, and structural proteins can act as receptors for drugs or endogenous agonists. However, richest sources of receptors are membrane-bound proteins that transduce extracellular signals into intercellular responses. Hydrophilic ligands interact with receptors that are found on cell surface. Hydrophobic ligands enter cells through cell membrane lipid bilayers to interact with receptors found inside cells. These receptors may be divided into four families: ligand-gated ion channels, G-protein coupled receptors, enzyme-linked receptors, intercellular receptors. Transmembrane ligand-gated ion channels. Extracellular portion of ligand-gated ion channels contain drug binding site. This site regulates port opening through which ions can flow across cell membrane, as we can see here. Channel is usually closed until receptor is activated by an agonist, when opens channel for a few milliseconds, depending on ion conducted through these channels. These receptors mediate diverse functions, including neurotransmission and muscle contraction. For example, stimulation of nicotinic receptor by acetylcholine opens a channel that allows sodium influx and potassium outflux across cell membranes of neurons or muscle cells. This change in ionic concentration across membranes generates an action potential in a neuron and contraction in skeletal and cardiac muscle. On the other hand, agonists stimulation of a subtype of the gamma aminobutyric acid receptor increases chloride influx, resulting in hyperpolarization of neurons and less chance of generating an action potential. Drug binding sites are also found on many voltage-gated ion channels where they can regulate channel function. For example, local anesthetics bind to voltage-gated sodium channels, inhibiting sodium influx and decreasing neural conduction. This figure is very important because this figure highlights the main types of receptors and their differences. So first, the location. Ligand-gated ion channels, G-protein coupled receptors, and receptor kinases all located on membrane, except nuclear receptor who are located on intracellular. Effectors are ion channels. In this case, in G-protein channel or enzyme, receptor kinases we already known as protein kinases, and gene transcription. Coupling, direct, J-protein or elastin, direct via DNA. Examples include, as we mentioned earlier, nicotinic acetylcholine receptor, GABA-A receptor, G-protein muscarinic acetylcholine receptor, adenoreceptors. Receptor kinases, example include insulin, growth factors, cytokine receptors. Nuclear receptor includes steroid receptors. Structure, ligand-gated ion channels are oligomeric assembly of subunits surrounding central pore. G-protein coupled receptors are monomeric or oligomeric assembly of subunits comprising seven transmembrane helices with intracellular G-protein coupling domain. Receptor kinases are single transmembrane helix linking extracellular receptor domain to intracellular kinase domain. Nuclear receptors are monomeric structure with receptor and DNA binding domains. Transmembrane G-protein coupled receptors. Extracellular portion of this receptor contains ligand binding site, and cellular portion interacts when activated with a G-protein. There are many kinds of G-proteins, for example, G stimulatory, G inhibitory, and GQ. But all types are composed of three protein subunits. Alpha subunits bind guanosine triphosphate. Beta and gamma subunits anchor G-protein in cell membrane, as shown in figure. Binding of an agonist receptor increases GTP, that is guanosine triphosphate binding, to alpha subunit, causing dissociation of alpha guanosine triphosphate complex from beta gamma complex. Alpha and beta gamma subunits are then free to interact with specific cellular effectors, usually enzyme or an ion channel, that cause further actions within cell. These responses usually last several seconds to minutes. Often activated effectors produce second messenger molecules that further activate other effectors in cell, causing a signal cascade effect. Common effector activated by G stimulatory and inhibited by G inhibitory is adenyl cyclase, which produces second messenger cyclic adenosine monophosphate. Effector phosphorylase C, when activated by GQ, generates two second messengers, inositol 1,4,5 triphosphate, that is IP3, and diacyl glycerol DAG. Both activates specific protein kinases within cell, leading to a myriad of physiological effects. IP3 increases intracellular calcium concentration, which in turn activates other protein kinases. This table shows G-protein coupled receptor families. Rhodopsin family, the largest group receptors for most amine neurotransmitters, many neuropeptides, purines, prostanoids, cannabinoids, etc. Short extracellular and terminal tail ligand binds to transmembrane helices, amines to extracellular loops, peptides. Secretin, glucagon receptor family. Receptors for peptide hormones, including secretin, glucagon, calcitonin. Intermediate extracellular tail incorporating ligand binding domain. C. Metabotropic glutamate receptor, calcium sensor family. Small group, metabotropic glutamate receptors, GABA B receptors, calcium sensing receptors. Long extracellular tail incorporating ligand binding domain. A fourth distinct family includes many receptors for phenomodes, but no pharmacology receptors. This table shows the main G protein subtypes and their functions. For example, G alpha stimulatory, many amine and the receptors, catecholamines, histamines, serotonin. G alpha inhibitory, also provide cannabinoid receptors. G alpha also provide cannabinoid receptors. G alpha Q amine peptide prostanoid receptors, and all G protein coupled receptors activate potassium channels, inhibit voltage gated calcium channels, activate G protein coupled receptor kinases, activate mitogen, activated protein kinase cascade, interact with some forms of adenyl cyclase and with phospholipase C beta. Enzyme link receptors. This family of receptors undergoes conformational changes when activated by a ligand, resulting in increased intracellular enzyme activity. This response lasts for minutes to hours. Most common enzyme link receptors, for example, growth factors and insulin, possess tyrosine kinase activity. When activated, receptor phosphorylates tyrosine residues on itself and other specific proteins. Phosphorylation can substantially modify target protein structure, thereby acting as molecular switch. For example, phosphorylated insulin receptor in turn phosphorylates other proteins that now become active. Thus, enzyme-linked receptors often cause a signal cascade effect like that caused by G-protein coupled receptors. Last, intracellular receptors. Fourth family of receptors differs considerably from other three in that receptor is entirely intracellular, and therefore ligand, for example, steroid hormones, must have sufficient lipid solubility to diffuse into cell or to interact with receptor. As shown in this figure, a lipid-soluble drug diffuses across the cell membrane and moves to the nucleus of the cell. The drug binds to a receptor. The drug-receptor complex binds to the chromatin, activated the transcription of specific genes, messenger RNA to specific proteins, and biological effects can be seen. Primary targets of activated intracellular receptors are transcription factors in cell nucleus that regulate gene expression, activation or inactivation of transcription factors, alter transcription of DNA into RNA, and subsequently translation of RNA into proteins. Effect of drugs or endogenous ligands that activate intracellular receptors takes hours to days to occur. Other targets of intracellular ligands are structured proteins, enzymes, RNA, and ribosomes. For example, tubulin is target of anti-neoplastic agents such as paclitaxel. Enzyme dihydrofolate reductase is target of antimicrobials such as trimethoprim. And 50S subunit of bacterial ribosome is target of macrolide antibiotics such as erythromycin. This figure shows a diagrammatic representation of nuclear receptors. The heterogeneous and terminal domain harbors the AF activation fraction 1. Side this side begins cell-specific transcription factors that modify the properties of the receptor. The highly conserved core domain comprises two zinc fingers, cysteine or cysteine histidine, which loops in the amino acid chain that are held in particular conformation by zinc ions and which are responsible for DNA recognition and binding. The flexible hinge region in the molecule allows the receptor to dimers with other NRs, and the C-terminal domain, which contains the ligand binding molecule, is specific to each class of receptor, as we can see in this figure. So, nuclear receptors are a family of 48 soluble receptors that send lipid and hormonal signals and modulate gene transcription. Their ligands are many and varied, including steroid drugs and hormones, thyroid hormones, vitamins A and D, various lipids, and xenobiotics. There are two main categories. Class 1 nuclear receptors are present in the cytoplasm, form homodimers in the presence of their partner, and migrate into the nucleus. Their ligands are mainly endocrine in nature, for example, steroid hormones. Class 2 nuclear receptors are generally constitutively present in the nucleus and form heterodimers with the retinoid X receptors. Their ligands are usually lipids, for example, the fatty acids. The ligandated receptor complexes initiate changes in gene transcription by binding to hormone response elements in gene promoters and recruiting co-activator or co-repressor factors. The receptor family is the target of approximately 10% of prescription drugs, and the enzyme that it regulates affect the pharmacokinetic of some 60% of all prescription drugs. This table shows some common pharmacological significant nuclear receptors that are androgen, the ligand is testosterone, estrogen, the ligand is 17-beta oestradiol, glucocorticoid, ligand is cortisol, corticosterone, progesterone is the ligand itself, mineralocorticoid, the ligand is aldosterone. So the mechanism of action is translocation to nucleus, binding to HREs with two half sites with an inverted response. Type 2 retinoid X, 9-cis-retinoic acid. These include retinoic drugs, retinoic acid, vitamin A, thyroid hormone, T3, T4, peroxisome proliferator, fatty acids, prostaglandins, rosiglitazone, and Pioglitazone are the main example of this receptor, constitutive androstenedione, androstenedione itself, and pregnan X xenobiotics. These mechanism of action is complexed with co-repressors which are displaced following ligand binding, allowing the binding of trans activators. So remember, there are two types of receptors. One are located in the cytosol, and the other located in the nucleus. So there are two locations and two ligand binding sites: homodimers, which are type 1, and type 2, which are heterodimers. So this should be remembered. Characteristics of signal transduction. Signal transduction has two important features: ability to amplify simple, small signals and mechanisms to protect cells from excessive stimulation. Signal amplification. Characteristic of G protein linked and enzyme linked receptors is ability to amplify signal intensity and duration via signal cascade effect. Additionally, activity G protein persists for a longer duration than doses against agonist receptor complex. Binding of albuterol, for example, may only exhibit a few milliseconds, but subsequent activity G protein may last for hundreds of milliseconds. Further prolongation and amplification of initial signals are mediated by interaction between G proteins and their respective intracellular targets. Because of this amplification, only a fraction of total receptors for a specific ligand may need to be occupied to elicit a maximal response. Systems that exhibit this behavior are said to have spare receptors. About 99% of insulin receptors are spare, providing an immense functional reserve that ensure adequate amounts of glucose enter into the cell. Only about 5 to 10% of total beta adenoreceptors in heart are spare. Therefore, little functional reserve exists in failing heart because most receptors must be occupied to obtain maximum contractility. Desensitization and down-regulation of receptors. Repeated or continuous administration of an agonist or antagonist often leads to changes in responsiveness of receptor. Receptor may become desensitized due to too much agonist stimulation, resulting in diminished response. This phenomenon called tachyplexis is often due to phosphorylation that renders receptors unresponsive to agonists. In addition, receptors may be internalized within cell, making them unavailable for further agonist interaction. Downregulation. Some receptors, particularly ion channels, require a finite time following stimulation before they can be activated again. During this recovery phase, unresponsive receptors are said to be refractory. Repeated exposure of a receptor to an antagonist or other hand results in upregulation of receptors, in which receptor reserves are inserted into membrane, increasing number of receptors available. Upregulation of receptors can make cells more sensitive to agonists and or more resistant to effects of antagonists. So this figure, we can see the response over time. Repeated administration of an agonist, that is epinephrine, for a short time period results in diminished response of the cell. Following a period of rest, administration of the drug results in a response of the original magnitude. Drug response relationships. Agonist drug mimic the action of the endogenous ligand for the receptor. For example, isoproterenol mimics norepinephrine on beta-1 receptors of heart. Magnitude of drug effect depends on receptor sensitivity to drug and drug concentration at receptor site, which in turn is determined by both drug dose administered and by drug's pharmacokinetic profile, such as rate of absorption, distribution, metabolism, and elimination, which we already discussed in pharmacokinetics, that is ADME. A for absorption, D for distribution, M for metabolism, E for elimination. Graded dose response relationship. As drug concentration increases, its pharmacological effect also gradually increases until all receptors are occupied maximum effect. Plotting magnitude of response against increasing drug doses produces a graded dose response curve that has general shape depicted in figure. Two important drug characteristics, potency and efficacy, can be determined by graded dose response curves. So here is the percentage of maximal effect with the drug. So drug A and drug B. So EC50 is the concentration of the drug that produces a response equal to 50% of the maximum response. In this case, the potency of the drug can be compared until using the EC50. The smaller the EC50, the more potent the drug. So potency is very important. Let's see what is potency. Potency is a measure of amount of drug necessary to produce an effect. Drug concentration produces 50% of maximum effect. It is EC50 is often used to determine potency. So we already see that in figure, EC50 of drugs A and B indicate that drug A is more potent. This drug A is more potent than drug B because a lesser amount of drug A is needed to obtain 50% effect. Therapeutic preparation of drugs reflect their potency. For example, candestran and it be certain or angiotensin receptor blockers used to treat hypertension. Therapeutic dose range for candencertain is 4 to 32 milligram as compared to 75 to 300 milligram for irbesartan. Therefore, candencertain is more potent than irbesartan. It has a lower EC50 value. Since range of drug concentration that cause from 1 to 99% of maximum response usually spans several orders of magnitude, semi-logarithmic plots are used to graph complete range of doses. As shown in this figure, curves become semi-sigmoidal in shape, which simplifies dose response curve interpretation in drug A and drug B. Efficacy. Efficacy is magnitude or response of a drug causes when it interacts with the receptor. Efficacy is dependent on number of drug receptor complexes formed and drug intrinsic activity, that is the ability to activate receptor and cause a cellular response. Maximum efficacy of drug, Emax, assumes that drug occupies all receptors and no increase in response is observed in response to higher drug concentrations. Maximum response differs between full and partial agonists, even when drug occupies 100% of receptors. Similarly, even though an antagonist occupies 100% of receptor sites, no receptor activation results and Emax is 0. Efficacy is more clinically useful characteristic than potency, since a drug with greater efficacy is more therapeutically beneficial than one that is more potent. This figure shows response to drugs of different potency and efficacy. So, here is biological effect with a logarithmic drug concentration. So, drug A is more potent in red color, but both show the same efficacy as drug B. Drug C shows lower potency and lower efficacy than drugs A and B. Effect of drug concentration or receptor binding. Quantitative relationship between drug receptor and receptor occupancy applies law of mass action to kinetics of binding of drug and receptor molecules. So drug plus receptor becomes drug receptor complex, and then the biological effect will appear. By making the assumption that the binding of one drug molecule does not alter the binding of subsequent molecules and applying the law of mass action, we can mathematically express the relationship between percentage or fraction of bound receptors and drug concentration. In this equation, D is free drug concentration, dr bound drug concentration, RT is the total number of receptors, KD is equilibrium dissociation constant for drug from receptor. Value of KD can be used to determine affinity of a drug for its receptor. Affinity describes strength of interaction and means binding between a ligand and its receptor. Higher KD value, weaker interaction of and lower affinity, and vice versa. So this equation defines a curve that has shape shown in figure when plotted against drug concentration panel A or log drug concentration panel B. As free drug concentration increases, ratio of concentration of bound receptor to total receptors approaches unity, thereby producing maximum effect. Thus, it is not surprising that curves shown in figure and those spreading the relationship between dose and effect are similar. Relationship of drug binding to pharmacologic effect. Law of mass action can be applied to drug concentration and response, providing following assumptions are met. Number 1, magnitude of response is proportional to amount of receptors occupied by drug. Emax occurs when all receptors are bound. One molecule of drug binds to only one molecule of receptor. In this case, E is the effect of drug at concentration D, and Emax is maximum drug effect. It follows that if a specific population of receptors is vital for mediating a physiological effect, affinity of an agonist for binding to those receptors should be related to potency of that drug for causing that physiological effect. Many drugs and most neurotransmitters can bind to more than one type of receptors, thereby causing both desired therapeutic effects and undesired adverse effects. In order to establish a relationship between drug concentration of particular receptor subtype and the corresponding biological response to that drug, correlation curves, as can be seen in the figures, this figure of receptor affinity and drug potency are often constructed and can be seen in different research articles also. Intrinsic activity is an agonist binds to a receptor and produces a biological response based on agonist concentration, its receptor affinity, and therefore fraction of occupied receptors. However, drug intrinsic activity further determines the ability to fully or partially activate receptors. Drugs may be categorized according to their intrinsic activity and resulting Emax values. So let's see what is full agonist, partial agonist, and inverse agonist. So, in this figure, a full agonist produces, as shown in this red color, complete activation of a receptor at high drug concentrations. The partial agonist, which is in blue color, binding results in less than 100% activation even at very high concentration. The green color shows inverse agonists produce a response below the baseline response measured in the absence of drug. In this example, a portion of the receptor show constitutive activity without stimulation such that 12% maximum response is seen. So let's try to explain this concept of full agonist. If a drug binds to a receptor and produces a maximum biological response that mimics endogenous ligand response, it is a full agonist. Full agonist binds to receptor, stabilizing the receptor in its active state and are said to have an intrinsic activity of 1. All full agonists of a receptor population should produce same Emax. Phenylephrine is a full agonist at alpha-adenoreceptors because it produces same Emax as endogenous ligand, norepinephrine. Upon binding to alpha-1 adenoreceptors on muscle-smooth muscle, both norepinephrine and phenylephrine stabilize receptor in its active state, thereby increasing GQ activation. Activation of GQ increases intracellular calcium, causing interaction of actin amide inflammants and muscle cells shortening. Diameter of arteriole decreases, causing an increase in resistance to blood flow through vessel and increase in blood pressure. Thus, effects of agonists on intracellular molecules, cells, tissues, and intact organisms are all attributable to interaction of drug with receptors. For full agonist, dose response curves for receptor binding and each of biological responses should be comparable. Partial agonist. Partial agonists have intrinsic activities greater than 0 but less than 1 because 1 will be full agonist. Even when all receptors are occupied, partial agonists cannot produce same Emax as a full agonist. Even so, a partial agonist may have an affinity that is greater than, less than, or equivalent to that of a full agonist. A partial agonist may also act as a partial antagonist of a full agonist, as shown in this figure. As number of receptors occupied by partial agonist increases, number of receptors that can be occupied by full agonist decreases, and therefore Emax would decrease until it reaches partial agonist Emax. This potential of partial agonists to act as both an agonist and antagonist may have therapeutic utility. For example, aripiprazole, an atypical antipsychotic, is a partial agonist at selected dopamine receptors. Overactive dopaminergic pathways tend to be inhibited by aripiprazole, whereas underactive pathways are stimulated. This might explain why aripiprazole ability to improve symptoms of schizophrenia with a small risk of causing extrapyramidal adverse effects. Inverse and agonist. Typically, unbound receptors are inactive and require interaction with an agonist to assume an active conformation. However, some receptors show a spontaneous conversion from inactive to active. In the absence of an agonist, inverse agonists, unlike full agonists, stabilize the inactive R form and cause inactive to convert to active. This decreases the number of activated receptors to below that observed in the response of drug. Thus, inverse agonists have an intrinsic activity less than 0. Less than 0. Reverse the activation state of receptors and exert the opposite pharmacological effect of agonists. So, full agonists have activity of 1. Partial activity have intrinsic activity is greater than 0 but less than 1. Inverse agonists have an intrinsic activity less than 0. So we can see that high levels of agonists may activate all receptors and produce unwanted OS stimulation. The presence of partial agonists displaces some agonists, resulting in diminished receptor response. And at high concentration of partial agonists, the agonist is completely displaced and receptor activity is determined by the intrinsic activity of the partial agonist. So let's see what is antagonist. Antagonists bind to a receptor with high affinity but with a 0 intrinsic activity. An antagonist has no effect on biological dysfunction in absence of an agonist, but can decrease effect of an agonist when present. Antagonism may occur either by blocking drug's ability to bind to receptor or by blocking its ability to activate receptor. So there are different types of antagonists. Competitive antagonist binds to same site or receptor as agonist in a reversible manner. It is competitive as competitive antagonist interfaces with an agonist binding to its receptor and maintains receptor in its inactive state. For example, antihypertensive drug terazocin competes with endogenous ligand norepinephrine and at alpha-1 adrenoceptor, thus decreasing vascular smooth muscle tone and reducing blood pressure. However, increasing agonist concentration related to antagonists can overcome this inhibition. Thus, competitive antagonists characteristically shift against agonist dose response curve to right, increase EC50 without affecting Emax. Irreversible antagonists. Irreversible antagonists bind covalently to active site of receptor, thereby permanently reducing number of receptors available to agonists, and causes a downward shift of Emax with no shift of EC50 values. As compared to competitive antagonists, addition of more agonists does not overcome effect of irreversible antagonists. Thus, irreversible antagonists and allosteric antagonists are both considered non-competitive antagonists. A fundamental difference between competitive and non-competitive antagonists is that competitive antagonists reduce against agonist potency. It means increase EC50, and non-competitive antagonists reduce agonist efficacy. It means decrease Emax. Allosteric antagonist, which is considered as non-competitive antagonist, binds to a site, allosteric site other than agonist binding site and prevents receptor activation by agonist. This type of antagonist also causes a downward shift of Emax of an agonist with no charge in EC50 value. Example is picrotoxin, which binds to inside of GABA-controlled chloride channel. When this binding inside channel, no chloride can pass through channel even when GABA fully occupies receptors. Functional antagonism or physiologic antagonism. Antagonists may act as a completely separate receptor, initiating effects that are functionally opposite those of agonists. Classic example is functional antagonism by epinephrine to histamine-induced bronchoconstriction. Histamine binds to H1 histamine receptors on bronchial smooth muscle, causing bronchoconstriction of bronchial tree. Epinephrine is agonist at beta-2 adrenoreceptors on bronchial smooth muscle, causing muscles to relax. So in this figure, we can see biological effect versus drug concentration. So red color is drug alone, and this color, orange color, is drug with non-competitive antagonist. So this is again drug with competitive antagonist. So we can see EC50 for drug alone is the presence of a non-competitive antagonist. EC50 for drug in the presence of competitive antagonist. Quantile dose response relationship. This is the relationship between drug, dose, and proportion of population of patient that responds to it. These responses are known as quantile responses because for any individual, either effect occurs or it does not. Gradient responses can be transformed to quantile responses by designing a predetermined level of gradient response as point at which a response occurs or not. This relationship can be determined in a population for antihypertensive drug atenolol. This positive response is defined as a fall of at least 5 millimeter of mercury in diastolic blood pressure. They have similar shapes as log dose response curves, and ED50 is drug dose that causes a therapeutic response in half of population. So let's see what is therapeutic index. This is a measure of drug safety. Is a ratio of drug dose that produces toxicity in half population, that is TD50, to dose that produces a clinically desired or effective response, that is ED50 in half population. So therapeutic index is equal to toxicity in half population, that is TD50, divided by effective response in half population, that is ED50. Larger value indicates a wide margin between doses that are effective and doses that are toxic. Clinical usefulness of therapeutic index is determined using drug trials and accumulated clinical experience. High therapeutic index values are required for most drugs. Some drugs with low therapeutic indices are routinely used to treat serious diseases. As we can see, there are two examples. One is warfarin, which has small therapeutic index. The other is penicillin, which is large therapeutic index. As warfarin dose is increased, a greater fraction of patient desired response is a 2 or 3-fold increase in international normalized ratio until eventually all patients respond. However, at higher doses of warfarin, anticoagulation resulting in hemorrhage occurs in a small percent of patients. Agents with a low therapeutic index are those drugs for which bioavailability critically alters therapeutic effects. Penicillin, as shown in figure B, is a safe and common to give doses in excess of that which is minimally required to achieve a desired response without risk of adverse effects. In this case, bioavailability does not critically alter therapeutic or clinical effects. So let's start with the question and answer session. This question and answer session will help us to better understand the concepts we have learned in the previous sections. So we will try to answer this question and we will see the different options to understand if we are capable to understand the concepts highlighted or described before. So let's start with question number 1. This question, 74-year-old man was admitted to the hospital for treatment of heart failure. He received 160 microgram of digoxin intravenously and plasma digoxin level was 0.4 nanogram per milliliter. A desired plasma concentration of digoxin for optimal therapeutic activity in heart failure is 1.2 nanogram per milliliter, and patient has an estimated VD of 400 liter. Calculate digoxin additional dose needed for this patient to achieve desired plasma concentration. So we know that VD, which is 400 liter, multiplied by 1.2, which is C2, minus C1 is 0.4 nanogram per ml. So 400 liter multiplied by 0.8 becomes 320 microgram. Somatostatin interacts with which of the following receptors? The answer is G inhibitory protein coupled receptors. Which characteristic gives cortisol the ability to target intracellular receptors? The ability is the diffuse through lipid membranes. 66-year-old man is admitted to hospital. Very interesting case again. So let's see what happens in this case. 66-year-old male is admitted to hospital with confusion, nausea, and blurred vision. So let's see. He is currently on digoxin, okay, for heart failure treatment. On physical exam, his heart rate is 120 BP per minute. Further evaluation reveals digoxin level of 5.3 nanogram per ml. Normal age is 0.5 to 2 nanogram per ml. Doctor believes his symptoms are due to digoxin toxicity. Which parameter is used to indicate digoxin ability to produce desired effect related to a toxic effect? So the answer is therapeutic index. Digoxin is an example of a drug with a very low therapeutic index, which requires frequent monitoring of the plasma level to achieve the balance between desired effect and unwanted toxicity. Potency of a drug is the amount of drug needed to produce a given response. Intrinsic activity of the drug is the ability to resist a response. Efficacy of the drug is the maximum drug effect that can be achieved in a patient under a given set of conditions. Bioavailability of a drug is the fraction of the drug that reaches the bloodstream unaltered. 64-year-old woman presents to emergency room with severe abdominal pain and feculent emesis. She has a history of multiple abdominal surgeries due to Crohn's disease. Further evaluation reveals a small bowel obstruction. A few hours later, she undergoes surgery for lysis of adhesions and resection of small bowel. Why should the use of oral medication be avoided in this patient? Very easy. Because of decreased passage of drug through intestine, adequate passage of drug through the small intestine is required to observe the effects of the drug. Because most of the absorption takes place in the small intestine, after extensive abdominal surgery, especially that involving a section of a portion of small bowel, the passage may be slowed or even stopped for a period of time. Abdominal surgery rarely results in reduced blood flow to the intestine, nor does such an operation influence protein binding or the first pass effect. Destruction of drug by stomach acid doesn't depend on intra-abdominal surgery. 82-year-old woman is admitted to hospital for management of heart failure exacerbations. She has peripheral edema and ascites due to exacerbation. Further evaluation also reveals a urinary tract infection requiring antibiotic treatment. Due to her history of heart failure, changes in what pharmacodynamic parameters should be considered prior to choosing most appropriate antibiotic dose. So the answer is increased volume of distribution. Because of patient edema ascites from heart failure, the apparent volume distribution will be increased, which may require small adjustment in the usual medication dose. Edematous states do not influence gastrointestinal blood flow, nor do they affect drug-protein interactions. Drug elimination may be slowed with a congestive heart failure exacerbation, not increased. Drug kinetics are generally not changed by edematous states. Which of the following best describes how a drug that acts as an agonist at a subtype of GABA receptors affects signal transduction in a neuron? So again, very interesting question. So let's see, the best option is activation of this receptor subtype opens ion channels, allows chloride to enter cells, and decreases chance of generating an action potential. Because the GABA A receptor is a ligand-gated ion channel, selective for chloride. Agonists for GABA A receptor increase opening of channels, resulting in chloride entry into the neuron, hyperpolarization, and decreased action potential events. If 1 milligram of lorazepam produces same and isolated response as 10 milligram diazepam, which is correct. So the correct option is lorazepam is more potent than is diazepam. A drug causes the same effect at lower dose is more potent. B and C are incorrect because without information about the maximum effect of these drugs, no conclusion can be made about efficacy or intrinsic activity. D is also incorrect because the maximum response obtained is often more important than the amount of drug needed to achieve it. If 10 milligram of oxycodone produces a greater analgesic response than does aspirin at any dose, which is correct. Oxycodone is more efficacious than is aspirin. Drugs with greater response at maximal effective concentration are more efficacious than drugs with a lower maximum response. Choice B is incorrect since no information is given about the half maximum concentration of either drugs. Choice C and D are incorrect since it has not known if both drugs bind to the same receptor population. In presence of propranolol, higher concentration of epinephrine is required to elicit full anti-asthmatic activity. Propranolol has no effect on asthma symptoms, which is correct regarding these medications. So the answer is epinephrine is an agonist and propranolol is a competitive antagonist. Since propranolol decreases the effect of epinephrine, but the inhibition can be overcome by giving a higher dose of epinephrine. Propranolol must be competitive antagonist. If D were correct, even very high concentration of epinephrine would not be able to elicit a maximum effect in the presence of propranolol. Since propranolol has no effect by itself, A and B is also correct. Incorrect. In presence of pyrotoxin, diazepam is less efficacious at causing sedation regardless of dose. Pyrotoxin has no sedative effect even at higher dose. Which of following is correct regarding these agents? Pyrotoxin is a non-competitive antagonist. Since pyrotoxin decreases the maximum effect of diazepam, regardless of diazepam dose, it is non-competitive antagonist. Pyrotoxin has no efficacy alone, so C is incorrect. No information is provided about potency of either drug. Haloperidol, chlorpromazine, clozapine are antipsychotic medications that bind to D2 subtype of dopamine receptors with a binding affinity of haloperidol greater than chlorpromazine, greater than clozapine. Which statement would have to be correct to conclude that mechanism of antipsychotic effects of these drugs is via binding to D2 receptors? The answer is positive correlation between should exist between affinity of these drugs to bind to D2 receptors and their potency for antipsychotic actions. To conclude, their mechanism of antipsychotic effect for these drugs is via binding to D2 receptors. There should be a positive correlation between the affinity of the drugs for D2 receptors and their potency for antipsychotic actions. Haloperidol should have the highest antipsychotic potency and clozapine the lowest. There is no guarantee the therapeutic effects and adverse effects are mediated by the same receptor population. Therefore, a different correlation may exist for the adverse effects and D2 receptor affinity. If there were spare beta-1 adrenergic receptors on cardiac muscle cells, which statement would be correct? A maximum effect of epinephrine is seen when only a portion of beta-1 adrenergic receptors are occupied. Only a fraction of the total receptors need to be bound to elicit a maximum cellular response when spare receptors are present. The other choices do not accurately describe the effects of having spare receptors. Which of following upregulates postsynaptic alpha-1 adrenergic receptors? So the answer is daily use of prazosin and alpha-1 receptor antagonist. Upregulation of receptors occur when receptor activation is lower than normal, such as when the receptor is continuously exposed to an antagonist for that receptor. Downregulation of receptor occurs when receptor activation is greater than normal because of continuous exposure to an agonist, as described in A, B, and C. Methylphenidate helps patients with attention deficit hyperactivity disorder maintain attention and perform better at school or work with an ED50 of 10 milligram. However, methylphenidate can also cause significant nausea at higher doses. TD50 is equal to 30 milligram, which is correct regarding methylphenidate. So we know the equation therapeutic index is equal to TT50 divided by ED50. Therapeutic index will be 30 milligram divided by 10 milligram. The answer will be 3. Therapeutic index of methylphenidate is 3. The next question is which is correct concerning safety of using warfarin with a small therapeutic index versus penicillin with a large therapeutic index. During previous lecture, during this lecture, we discussed about the therapeutic index of small and large. So the answer will be agents with a low therapeutic index. That is, drugs for which dose is critically important are those drugs for which bioavailability critically alters the therapeutic and adverse effects. A is correct because a drug with a low therapeutic index is not generally considered to be safe. C is incorrect because a high therapeutic index does not ensure safety across the entire patient population. D is also incorrect because a high therapeutic index makes it ultimately unlikely that bioavailability alters the incidence of therapeutic or adverse effects. So the correct option is warfarin treatment has a high chance of resulting in dangerous adverse effects if bioavailability is altered. Let's see the next question. Again, very important. Which of following term is used to describe elimination via metabolism catalyzed by alcohol dehydrogenase when enzyme is saturated? Is 18 years old female patient is brought to the emergency department due to drug overdose. Which of following routes of administration is most desirable for administering antidote for drug overdose? The answer is intravenous, because we know that intravenous route of administration is the most desirable because it results in achievement of therapeutic plasma levels of the antidote rapidly. Drug A is a weekly basic drug with a pKa of 7.8. If administered orally, at which of following site of absorption will drug be able to readily pass through the membrane? The answer is jejunum, because the pH approximately is 8.0. As drug A is a weekly basic drug, pKa is 7.8, it will be predominantly in the non-ionized form in the jejunum, that is pH 8.0. For weak bases, the non-ionized form will permeate through the cell membrane readily. KR2250 is an investigational cholesterol-lowering agent. KR2250 has a high molecular weight and is extensively bound to albumin. KR2250 will have dash apparent volume distribution. So we know that if there is high molecular weight, there will be high protein binding. So KR250 will be effectively trapped within the plasma vascular compartment and will have a low apparent volume of distribution. 40-year-old male patient, 70 kg, was recently diagnosed with infection involving methicillin-resistant Staphylococcus aureus, that is MRSA. He received 2000 milligram of vancomycin as an intravenous loading dose. Peak plasma concentration of vancomycin was 28.5 milligram per liter. Apparent volume distribution is. So here we have to use this equation, that is apparent volume distribution is equal to dose divided by C0. So 2000 milligram is the dose divided by 28.5 milligram per liter C0. The volume distribution will be 70.1 liter. Then we have to divide volume distribution by weight to get volume distribution in 1 liter per kg. So volume of distribution per weight of the person. 55-year-old woman is brought to emergency department because of seizures. She has a history of renal disease and currently undergoes dialysis. She receives intravenous infusion of anti-seizure drug X. Which of following is likely to be observed with use of drug X in this patient? So, as we know from the information of the question, the patient has a renal disorder. She may not be able to excrete the drug effectively. Therefore, the half-life of drug X will be prolonged. So, and then as the half-life will be prolonged, the doses must be reduced so the patient will not have serious toxic effects of drug X. So the correct option is D. 68-year-old woman is brought to the emergency department for treatment of a myocardial infarction. She is currently taking clopidogrel, that is antiplatelet agent, and aspirin daily, as well as omeprazole, that is potent CYP inhibitor for heartburn. Which of the following is most likely contributed to her myocardial infarction today? The answer is reduced antiplatelet activity of clopidogrel due to omeprazole. We know that clopidogrel is prodrug and requires CYP2 C19 activity for conversion to an active metabolite. Because omeprazole is a potent CY inhibitor, as mentioned in the question, clopidogrel is not converted to the active metabolite, and therefore the antiplatelet activity is reduced, potentially contributing to myocardial infarction. Which of the following reaction represents phase 2 of drug metabolism? The answer is sulfation. Phase 2 metabolic reactions involve conjugation reactions to make phase 1 metabolites more polar. Sulfation and glucuronidation are the most common phase 2 conjugation reactions. Pharmacokinetic study of a new antihypertensive drug is being conducted in healthy human volunteers. Drug half-life after administration by continuing intravenous infusion is 12 hours. Which of following best approximates time for drug to reach steady state? The answer will be 48 hours. Our drug will reach steady state in about 4 to 5 half-lives. Therefore, for this drug with a half-life of 12 hours, the approximate time to reach steady state will be 48 hours. 64-year-old female patient, 60 kg, is treated with experimental drug A for type 2 diabetes. Drug A is available as tablets with an oral bioavailability of 90%, or we can say 0.9. If volume of distribution is 2 liter per kg and desired steady state plasma concentration is 3 milligram per liter, which of following is most appropriate oral loading dose of drug A? So we know the formula or equation for loading dose. Loading dose is volume of distribution multiplied by desired steady state plasma concentration divided by bioavailability. So let's first calculate the volume of distribution. So volume of distribution divided by weight. So 2 liter per kg. So 2 liter per kg means 2 liter per 60 kg. So it will become 120 liters. So the volume distribution will be 120 liters. So we can place here volume distribution multiplied by 3.0, that is desired steady state plasma concentration, divided by the bioavailability, which is 0.9 or 90%. So the loading dose will be 400 milligram. So the answer is zero order kinetics. Alcohol, ethanol is one of the few drugs that follow zero order kinetics. That is, higher drug concentrations are not metabolized because enzyme that is involved in the process is saturable. In first order kind elimination, the rate of elimination actually depends on the concentration of the drug multiplied by the proportionality constant. Clearance is a measure of the capacity of the body to remove the drug. Biotransformation refers to the general mechanism of a particular drug elimination. Redistribution is one of the possible fates of drug which usually terminates drug action. Which of the following statements are true in regard to glucuronidation reactions? Require an active center as site of conjugation. Glucuronidation reactions which are considered phase 2 reactions requires an active center, a functional group, as a site of conjugation. Phase 1 reactions are biotransformation reactions, not conjugation reactions. Alcohol dehydrogenase is an example of phase 1 reaction. Nicotinamide adenosine dinucleotide phosphate is required for an aromatic hydroxylation, an example of phase 1 reaction. 38-year-old woman represents to her psychiatrist for management of depression. She feels that her current treatment is ineffective and would like to switch medications. Patients reveal that she drinks alcohol every night to relieve her feelings of sadness and guilt. Blood work is positive for elevated liver enzymes. Doctor starts imipramine, which has an extensive first-pass metabolism. How would this drug be effective? By increasing the concentration. First-pass metabolism simply means passage through the portal circulation before reaching the systemic circulation. In the face of liver dysfunction, drug levels may reach higher concentration. Bioavailability of drug is reduced, not increased, by the fraction removed after the first pass through the liver. Drugs are usually less rapidly metabolized when hepatic enzymes are elevated, which indicates hepatic dysfunction. Solubility of drugs not increased, not associated with hepatic damage. 24-year-old female is prescribed erythromycin for gastroparesis. It is prescribed 4 times daily due to its short half-life, which is the rationale for such a frequent dosing. Achieve steady-state plasma concentration of drug. Dosing schedule of drugs are adjusted according to their half-life to achieve steady-state plasma concentration. Attempting to avoid the toxicity of drug because of its low therapeutic index represents an unlikely scenario, since to reduce toxicity of drug with a low therapeutic index, one would reduce the dosing schedule, not increase it. Distribution of drug is generally not affected by dosing schedule, nor is dose scheduling affected by past metabolism. Some fluctuation in plasma concentration occurs even at steady state. It is the average concentration over time that is the goal of steady state. 78-year-old woman is started on digoxin for management of congestive heart failure. Her initial dose is 0.2 milligram, 0.25 milligram. C0 obtained by extrapolation of elimination phase is determined to be 0.05 milligram per liter. What is patient estimated volume of distribution? So to calculate the volume of distribution, use the formula in which the dose of the drug is divided by the plasma concentration. So 0.25 milligram is divided by 0.05 milligram per liter, giving the result of 5 liter for volume of distribution. Drug has volume of distribution of 50 liter. At plasma concentrations over 2 milligram per liter, it undergoes zero order elimination at rate of 2 milligram per hour. If patient is brought to emergency room with plasma concentration of 4 milligram per liter of drug, how long it will take in hours for plasma concentration to decrease by 50%? For the plasma concentration of drug to decrease by 50%, half of the drug present in the body initially must be eliminated. The amount of drug in the body initially in the volume is the volume distribution multiplied by plasma concentration, that is 50 liter, multiplied by 4 milligram per liter. The result will be 200 milligram. When the plasma concentration falls to 2 milligram per liter, the body will contain 100 milligram of dose, that is 50 liter, multiplied by 2 milligram per liter, that is 100 milligram. Since the body eliminates the drug at a rate of 2 milligram per hour, it will require 50 hours for 100 milligram of the drug to be eliminated. 100 milligram tablet of drug X is given to a patient every 24 hours to achieve an average steady-state plasma concentration of 10 milligram per liter. If dosing regimen is changed to 150 milligram tablet every 12 hours, what will be a resulting average plasma concentration in milligram per liter of drug after 5 half-lives? The initial 100 milligram tablet every 24 hours in a dose rate of 4.17 milligram per hour, 100 divided by 24 is 4.17, which is the same dose rate as 150 milligram tablet every 12 hours. 50 divided by 12, 4.17. Thus, the average plasma concentration will remain the same, but decreasing both the dose and the dose interval will decrease the peak to trough variation of plasma concentration. A 35-year-old woman is started on ceftriaxone as empiric therapy for meningitis. Following intravenous administration, the initial rates of drug distribution to different tissues depend primarily on which of the following parameters. So that will be blood flow to tissues. The initial rate of distribution of a drug to a tissue depends primarily on the rate of blood flow to that tissue. At longer times, however, drug may undergo distribution among various tissues. For example, a very lipophilic drug may become concentrated in adipose tissue with time. Drug is administered in form of an inactive prodrug. Prodrug increases the expression of a cytochrome P450, which converts it to as its active form. With chronic long-term administration of prodrug, which of following will be observed. So the potency will increase. The induction of the cytochrome P450 following chronic administration will increase the conversion of the inactive product to its active form. This will shift the dose response curve of the product to the left, increase its potency without changing the efficacy. Which subfamily of cytochrome P450 is responsible for highest fraction of clinically important drug interactions resulting from metabolism? The answer is CYP3A. Subfamily is responsible for roughly 50% of total cytochrome P450 activity present in the liver and is estimated to be responsible for approximately half of all clinically important untoward drug interactions resulting from metabolism. If oral dosing rate of a drug is held constant, what will occur if the bioavailability is increased? If the bioavailability will increase, increased steady-state plasma concentration will be observed. So, if the oral dosing rate is constant but the availability increases, the fraction of the administered dose that reaches the general circulation unaltered increases. Thus, in turn, they will increase the steady-state plasma concentration. 45-year-old man is given an oral maintenance dose of drug calculated to achieve a steady-state plasma concentration of 5 microgram per liter. After dosing the patient for a sufficient amount of time to reach steady state, the average plasma concentration of drug is 10 microgram per liter. A decrease in which of following parameters may explain the higher than anticipated plasma drug concentration? The answer is clearance. Steady state plasma concentration of drug is equal to dose rate divided by clearance. Thus, a decrease in clearance will increase the plasma drug concentration, whereas an increase in any of the other three parameters will decrease the steady state plasma concentration, either bioavailability, half-life, or volume distribution. Administration of an intravenous loading dose of drug X yields an initial plasma concentration of 100 microgram per liter. Table below illustrates plasma concentration of drug X as a function of time after initial loading dose. What is half-life in hours of drug X? So, again, we need to calculate. Inspection of the plasma concentration values indicate that the half-life of drug does not become constant until 1 to 9 hours after administration. As shown in this table, the drug concentration decreases by half from 50 to 25 microgram per liter between 1 to 5 hours, a 4-hour interval, and again decreases by half from 25 to 12.5 microgram per liter between 5 and 9 hours, again 4-hour interval. This indicates that half-life of the drug is 4 hours. The rapid decrease in plasma concentration between 0 and 1 hour, followed by a lower or slower decrease thereafter, and the constant half-life thereafter, indicating that this drug obeys a two-compartment model with the initial distribution phase followed by an elimination phase. The half-life is always determined from the elimination phase data. Which of the following factors will determine the number of drug receptor complexes formed? So the answer is receptor affinity for drug will determine the number of drug receptor complexes formed. Efficacy is the ability of the drug to activate the receptor after binding has occurred. Therapeutic index is related to safety of the drug. Half-life and secretion are properties of elimination and do not influence the formation of drug receptor complexes. Which of the following is an action of a non-competitive antagonist? It will decreases maximum response to an agonist. A non-competitive antagonist decreases the magnitude of the response to an agonist but does not alter the agonist potency, that is ED50 remains unchanged. A competitive antagonist interacts at the agonist binding site. Renal clearance of drug is 10 milliliter per minute. Drug has low molecular weight and is 20% bound to plasma proteins, and it is most likely that renal excretion of this drug involves which of the following mechanisms? The answer will be glomerular filtration and passive tubular reabsorption. This drug will undergo filtration and passive reabsorption. Since the molecular weight of the drug is small, but does not alter as small, free drug will be filtered because 20% of the drug is bound to plasma protein, 80% of it is free and available for filtration, which would be at rate of 100 ml per minute. That is 0.8 into 125 ml per minute. 125 ml per minute is the normal glomerular filtration rate. A clearance of 10 ml per minute must indicate that most of the filtered drug is reabsorbed. Let's see the next question. Which route of drug administration is used with potent and lipophilic drug in a patch formulation and avoids first-pass metabolism? The answer is transdermal. The topical, sublingual, rectal, suppositories, and transdermal route of administration all avoid first-pass hepatic drug metabolism. However, only the transdermal formulation uses a patch with potent and lipophilic drugs. Orally administered drugs have the highest exposure to first-pass metabolism. Which one of following routes of administration does not have an absorption phase? The answer will be intravenous. Drug absorption refers to the process by which drugs get into the bloodstream, with subcutaneous, intramuscular, sublingual, or inhalation routes of administration. Drug molecules have to cross membranes to get into the blood. Direct delivery of drug into the blood by intravenous administration therefore has no absorption phase. Which of following correctly describes intramuscular route of parenteral drug administration? The answer will be used to administer drug suspension that are slowly absorbed. After intramuscular injection of a suspension of drug particles, the particles slowly dissolve in interstitial fluid provide sustained drug absorption over many hours or days. When a drug solution is injected intramuscularly, the drug is usually absorbed rapidly and completely. An elderly patient has problems remembering to take her medication 3 times a day. Which one of the drug formulation might be particularly useful in this case? The answer is extended release. Using an extended release tablet or capsule, the patient could most likely reduce the schedule of medication from 3 times a day to once a day. A suspension for oral administration would not likely reduce the schedule. A suppository would be difficult and reduce patient compliance. And a skin patch for transdermal administration would work only in a few cases with potent and highly lipophilic drugs. Enteric-coated preparations may help absorption or drug stability, but would not reduce the schedule of medication. Which form of a drug name is most likely known by patients from exposure to drug advertisement? That is trade name or brand name. The proprietary name, also known as a trade name or the brand name, is a name trademarked by the manufacturer and promoted on television, radio, and print advertisements. The chemical name is rarely seen, being tedious and descriptive only to medicinal chemists, whereas the generic name may be seen in the fine print of the advertisement but is not usually promoted as extensively as the proprietary name. The non-proprietary name is the same thing as the generic name, and the British approved name is an official name that is usually the same as a generic name. Let's see the next question. If food decreases the rate but not extend absorption of particular drug from gastrointestinal tract, then taking drug with food will result in smaller maximal plasma drug concentration. If the rate of drug absorption is reduced, then the maximum plasma drug concentration will be less because more time will be available for drug distribution and elimination while the drug is being absorbed. Moreover, the time at which the maximum plasma drug concentration occurs will increase. If the extent of drug absorption fraction absorbed does not change, then the area under the curve and fractional bioavailability will not change. If a drug exhibits first order elimination, then rate of drug elimination milligram per minute is proportional to the plasma drug concentration. In first order elimination, drug half-life and clearance do not vary with the plasma drug concentration, but the rate of drug elimination quantity per unit time is proportional to plasma drug concentration at any time. After a person ingests an overdose of an acquired analgesic, plasma drug concentration is found to be 32 milligram per liter. How long will it take to reach a safe plasma concentration of 2 milligram per liter if drug's half-life is 6 hours? So, the answer is 24 hours. The half-life is the same is time required to reduce the plasma drug concentration 50%. In this case, it will take 4 drug half-lives or 24 hours to reduce the plasma level from 32 to 2 milligram per liter. What drug dose should be injected intravenously every 8 hours to obtain an average steady-state plasma drug concentration of 5 milligram per liter if drug volume distribution is 30 liter and its clearance is 8 liter per hour. So steady-state plasma drug concentration multiplied by clearance multiplied by time. So 5 milligram per liter multiplied by 8 liter per hour multiplied by 8 hours gives 320 milligram as the answer. So the dose required to establish the target plasma drug concentration is calculated by multiplying the clearance by target concentration and dosage interval, that is time. So the next question is volume distribution of a drug will be greater if drug is more ionized inside cells than in plasma. When a drug is more ionized inside cells, the drug becomes sequestered into the cells and the volume distribution can become quite large. This is called ion trapping. Description of molecular events initiated with ligand binding and ending with a physiological effect is called signal transduction pathway. Pharmacodynamics is the study of the detailed molecular pathway starting from drug ligand binding to its receptor, the activation of effector molecules, that is G proteins, and the generation of second messengers, which ultimately produce an effect that can be measured at the cell, tissue, or whole animal level. This process is called the signal transduction pathway. G protein coupled receptors that activate an inhibitory G alpha subunit alter activity of adenyl cyclase to decrease production of CAMP. Adenyl cyclase is an enzyme that converts ATP to cyclic AMP. G protein coupled receptors that activate inhibitory G alpha subunits are known to inhibit adenyl cyclase and therefore reduce generation of CAMP. CAMP is the second messenger in the system, even though in this case its levels are decreased. Activated G-alpha subunits also have direct effects on ion channels. Law of mass action explains relationship between concentration of drug and its association or dissociation of drug receptor complex. The law of mass action is used to derive the affinity of a drug for its receptor and is noted as the KD. KD, which is the equilibrium dissociation constant, comes from the kinetic rate K2 of drug receptor dissociation divided by the rate K1 of drug receptor association. In a log dose response plot, drug efficacy is determined by maximum height of measured response on effect axis, whereas drug potency is determined by position of the curve along the log dose axis. Potency and efficacy can be determined from a graph of the log dose response curve by visual inspection. The height of the curve along the effect on y-axis is a measure of efficacy. The placement of the curve along the log dose axis on x-axis determines potency, such that curves to the left represent more potent drugs than curves to the right. Thus, it is because curves to the left gives rise to smaller doses of a drug near to a 50% effect or ED50. As we know, ED50 is a measure of drug potency but says nothing of efficacy. Whereas some agents are potent and efficacious, these two characteristics of drug action are not necessarily correlated. It is possible to have an agent that is highly potent but doesn't have great efficacy. Partial agonist is best described as an agent that cannot produce full effect even at high doses. An agonist acts at its receptors to activate the signal transduction pathway and produce an effect. An antagonist binds to its receptor, producing no effect at the receptor, but rather blocks the receptor so that agonist cannot bind and produce an effect. A partial agonist binds to the receptor and activates the signal transduction pathway, but not to the maximal degree. Because the degree to which a ligand activates receptor is called efficacy, it is clear that partial agonists do not have full efficacy. Which of the following drug interaction mechanism is most likely to lead to sustained elevation of plasma drug concentrations and drug toxicity? The answer is inhibition of CYP3A4. Inhibition of drug metabolizing enzymes will increase the half-life and plasma concentrations of affected drugs, thereby posing a risk of toxicity. Induction of these enzymes will reduce half-life and plasma levels. Displacement of a drug from plasma proteins or inhibition of P-glycoprotein might increase plasma levels temporarily until the rate of elimination increases. Acceleration of the gastric emptying rate increase the rate of drug absorption but would not permanently increase plasma drug levels. Elderly persons may have altered drug disposition because of reduced capacity of oxidized drugs. Conjugation metabolism is relatively unchanged in the elderly, but oxidative drug metabolism is usually reduced. The elderly tend to have a higher percentage of body fat than younger adults and therefore have increased volumes of distribution of fat-soluble drugs. Drug absorption is not typically altered in the elderly and their blood-brain barrier is not noticeably impaired in most cases. 79-year-old man with end-stage Alzheimer's disease and dysphagia is taking multiple medications. Physical examination reveals xerostomia and a limited gag reflex. Which of following routes of medication administration would provide lower serum drug concentration? The answer is anteral. 28-year-old man with seborrheic dermatitis is prescribed a topical corticosteroid cream by his dermatologist in hopes of alleviating chronic rash and erythema on the cheeks. Which of following steps is most critical to achieve a therapeutic drug concentration in plasma? That is absorption. 31-year-old man is brought to the emergency department complaining of dyspnea. He has history of asthma and has had multiple asthma attacks requiring intubation for airway maintenance. He is non-compliant with his medications prescribed for his condition. Physical examination reveals a young man in acute distress. His room air oxygen saturation is 87%. In addition to administration of oxygen, immediate drug admission of albuterol should be administered by which of the following routes? So the answer will be inhalation. That is the best route of administration for this patient.